You're watching Ready or Not. What is motivational interviewing? Behaviour change approaches for smoking cessation in general practice. Produced by GP Supervision Australia and presented by Dr. Eileen Cole and Dr. Sasha Filia. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders, past, present, future, and their families.
I'm thrilled to have two experts in the field of motivational interviewing and smoking cessation to join us. Can I introduce Eileen Cole? Eileen's the GP lead for QUIT, and she also works as a medical advisor for the Department of Health and Aged Care and a sessional lecturer at Deakin University, interested in the prevention of chronic disease, health systems and patient safety. And accompanying Eileen is Sasha Filia. Sasha is the cessation advisor for QUIT Centre. That's a fantastic title, Sasha. I've got to say, the cessation. Just stop. I love it. She is very experienced in this field, published lots of papers and developed protocols and lots of training. And I think a particularly challenging area around people who smoke and live with mental illness. And more recently, expertise in vaping cessation. And I know, Sasha and Eileen, this will be a topic of interest for this session and the one we're following up with. And has coordinated the update of the National Minimum Quit Line Standards to support the provision of nationally consistent behavioural interventions for smoking and vaping cessation. And I think that's a really important element of your bio, because that whole notion of how we do this in a systematic way, I think, is a theme of what you're covering. And my name's Simon Morgan. I'm a GP, a medical educator with GPSA and the RACGP, and I'm joining you from a Wabakal country. And of course, the focus is twofold. One, on your own role as clinicians, but obviously very importantly, your role as supervisors and how to instill this incredibly important skill in your learners. So I'll hand over. Eileen, thanks. Sasha, I'll leave you to it.
Thanks very much, Simon. And thanks everyone for coming along. We're really excited to be able to talk about our favourite topic with a group of really interested and motivated clinicians who are teaching the next generation of GPs. We really hope that by the end of this session that you'll have an understanding about how to think about motivational interviewing and talk about motivational interviewing with your registrars, and encourage them to apply the skills and knowledge that you're sharing with them to be able to provide smoking cessation care and best practice smoking cessation care to their patients. So just to start off, we're setting the scene. And we all know that quitting smoking and now also quitting vaping is hard. Tobacco dependence is really, we need to think about it less as a behaviour and more as a chronic condition, because we know that tobacco dependence is underpinned by nicotine addiction. And most people will try and fail repeatedly to stop smoking before they achieve smoking cessation in the longer term. And even though some people will be able to quit the first time they try, by the time someone gets to 40, they've more than likely had at least 20 attempts to quit smoking before they can achieve this long term. And we know from Australian research that an average person will make an attempt to quit smoking, which may be successful for just over 24 hours, at least once a year. But I guess the positive side of that is that every time someone tries and fails to quit smoking, they learn something about their smoking behaviours from their quit attempt, which is why we sort of try and encourage people to say, it takes practice, don't despair. If you've tried to quit smoking and failed, keep at it. But it's really important for us as health professionals, when we've got patients in front of us, to offer help and to think about the best way to offer help. And when we're chatting with patients about their smoking and their smoking cessation attempts, we can sort of provide advice to them and provide support. And if we share with them that while people can quit without assistance, most people will have better success if they use some form of help. So we'd never discourage people from trying to quit unassisted, and some people take it as a badge of honour. But if we can sort of normalise the fact that it's okay to have some help, and that help will actually be more effective in getting you to quit longer term, then we need to sort of incorporate that into conversations as a standard of care. And I think offering support is especially important for those people who've tried and failed many times, because they can actually become quite despairing and think that they're never going to succeed. And it's likely that those patients in particular will be nicotine dependent and especially require some pharmacotherapy to help them. And what we know about what works for smoking cessation is that a combination of brief advice from a health professional plus pharmacotherapy and behavioural intervention have additive effects. So what that means is if we're in the clinic and we provide some advice about the best way to quit smoking to a patient, that in itself, that conversation is effective. It can help people to increase the likelihood of making a quit attempt. But if we combine that advice with pharmacotherapy to help patients deal with withdrawal symptoms and cravings, plus multi-session behavioural intervention, and the multi-session being a very important word there, which helps people to identify their triggers, develop strategies for managing their quit attempt, and importantly, shift their identity from someone who smokes to someone who doesn't, then the likelihood of successful quitting is actually more than doubled. And so if we can think about that as a treatment, that combination of brief advice is sort of a recruitment into the active treatment, which is the pharmacotherapy and the multi-session behavioural intervention. So brief advice is the upfront. It's the part that we can do within any clinical setting, especially in clinical settings where it's really relevant. Say, for example, someone who's having some wound care done or someone who's in preconception planning. We've all got a range of those clinical scenarios where we know that this is a key opportunity to talk to someone about their smoking. So if we just think that brief advice is actually advice from any health professional in our practice, but especially from us as GPs, about the best way to quit smoking and the benefits of quit smoking. It's a short conversation and it connects people to best practice cessation care. So Quit's developed a 3-step brief advice model, which is ask, advise, help. You can see a nice infographic on the screen there. But the 3 steps really are that we ask all patients about their smoking and we document it in the clinical record, and that we provide advice to all patients who smoke to quit. And this advice and the tone of this advice is extremely important, that if it's seen as a gain, it's approached in a gain rather than a loss, or as something that's sort of authoritarian, then it can open up the conversation. So the advice should be language that is not confrontational, and the messaging should be personally relevant to that patient. And it includes advice about the best way to quit. And then the third part is the help part, which is extremely important. And we can offer help to all patients who smoke, even those who are not super keen. And the help that we offer patients should be an offer of a referral to Quitline or other multi-session behavioural intervention, and help by initiating pharmacotherapy if that's something that the patient's interested in. So it can be delivered really quickly, even though it seems complex. It can be really just delivered in a short conversation where you're saying, well, the best way to quit is a combination of pharmacotherapy and behavioural support. Can I talk to you more about that? And that just gives us an idea of where the patient's at that particular time. And it's important to remember that even though people may refuse that offer during the consultation, you've already provided information to the patient that's about quitting, and also signalled that you're someone who's willing to help a patient. The 5 A's is the model that we're really familiar with, and it's more comprehensive. So the evidence shows that the more intensive advice, say more than 10 minutes, can be more effective. It's also the brief advice up to 3 minutes has been shown to be effective. The 5 A's is a comprehensive framework for delivering cessation care, and it can take longer. But if you said to someone, look, I can offer you help to quit smoking, and then you set up a subsequent consultation, the 5 A's can be a framework then that you assess the patient, you assess their level of nicotine dependence, and you actually commence treatment. So they're not mutually exclusive. And if you're short on time and there's other things happening in the consultation, you can deliver ask, advise, help, the 3-step. Or if you've got a dedicated time, you can deliver more comprehensive advice through the 5 A's. They're both stepped out in the RACGP guidelines. The hugely important thing for me, which was a game changer for me in thinking about my approach to smoking cessation, was that delivering brief advice doesn't require you to ask someone if they're ready to quit. It's quite a confronting message. And I don't know about you, but if sometimes you're sitting with the patient in front of you and they're a bit tense up and they know that you're going to ask them about smoking and they're really defensive up front. And so if you get to the point where you say, well, are you ready to quit? And they say, well, I just can't. then you can either launch into motivational interviewing or the conversation can end there and there's not actually an offer of help that follows it. Whereas if you give brief advice, it always includes an offer of help, even if you're getting the sense that the person is not super keen to quit at the moment. And I love this table, which came out in a research paper from Canada in 2022, which showed how effective brief advice is in terms of number needed to treat to prevent one death in primary care, compared to things that we do all the time, prescribing statins, prescribing antihypertensives for mild hypertension. So it's an effective treatment. So I think it's important that we just remember it and think of it as a positive treatment that we're offering to a patient rather than sort of a challenging request that we're asking them to do. And fundamental is the offer of help using AAH. And there's a suite of options that you can provide as help depending on how you sense the patient is at the time and also how much time you've got, what else is happening in the consultation. And importantly, if we are in clinic and we've got nurses helping us do chronic disease management plans and they're providing AAH, then they may have already provided patients with some or all of these options. So if a patient's not willing to engage or you're really busy, you can provide AAH and give them a printout of some information from the Cancer Council, or just give them the quit.org.au website, and there's a suite of tools and resources on that page where the patient can explore and educate themselves. There's also the My Quit Buddy app, which is available online. If you're sensing there's some ambivalence and you may be able to get some inroads for that patient, you may suggest some clinical follow-up and use some motivational interviewing, which Sasha will talk about, to really explore the barriers for that patient and start to make inroads into setting a quit date and moving forward. And if someone's really keen and ready to go, you can make a referral to Quitline and get started in thinking about some pharmacotherapy to reduce withdrawal symptoms and cravings. This is just a note on commencing treatment because we're really focusing on the behavioural intervention side of treatment at this time. But I just wanted to bring your attention to when we're thinking about pharmacotherapy. So the pharmacotherapy side of treatment is really important in the early stages when people will be experiencing the stronger cravings and nicotine withdrawal symptoms. So in deciding whether pharmacotherapy is clinically appropriate for an individual patient, an assessment of nicotine dependence is really important. And nicotine dependence can be assessed using the heaviness of smoking index. But I know Nick Zwar, who was instrumental in helping in writing the RSCGP guidelines, said that for people who are smoking within 30 minutes of waking and who are smoking more than 10 cigarettes a day are likely to be nicotine dependent and will benefit from pharmacotherapy. So with that in mind, we developed a nicotine replacement therapy tool, the Quit Centre, which we've got a screenshot there, which would help you in product selection for nicotine replacement therapy according to the patient's level of nicotine dependence. And pharmacotherapy guidelines are stepped out really well in the RACGP guidelines. So in choosing pharmacotherapy, it's really a shared decision-making process between you and the patient according to clinical factors, what else is happening, what other medications the patient may be on, the preferences in terms of what they've tried in the past, and also obviously cost. Now on to the key topic for the day. So the other part of active treatment is the behavioural intervention and support. And key in the studies is for us to realise that the behavioural intervention and support that's been demonstrated to be effective is that multi-session intensive behavioural support that's delivered by counsellors who are trained cessation specialists. So we've got a range of options for people to be able to access this behavioural intervention. If people have particular cessation interest and skills, that you can deliver it yourself in clinic. You can refer to local stop smoking services within your area. You can refer to Quitline, and you can refer people to psychologists. And multi-session behavioural intervention can be delivered either individually or in the group setting. So again, the type of services that people access is a shared decision-making process, but I'm really plugging for Quitline because it's free when we refer the patient and it's telephone-based, so it's extremely accessible no matter where you are. And we'll talk more about how Quitline works and the services that it offers. But whichever service you decide to refer a patient to, the service will need to help the patient with the three main tasks of quitting. which is to make a quit attempt, which involves being motivated and feeling confident to make a quit attempt. The second task is to be able to cope with the early stages of quitting, which is being able to deal effectively with their cravings and manage withdrawal symptoms. And the third task, which I think we underestimate, is that patients need to embrace a lifestyle free from smoking, which for some people if you've been smoking for a long time, involves significant changes in what you do each day. It may impact on relationships and social activities, and that can feel overwhelming and almost impossible. So it can take some time for patients to be able to shift that identity. And the other important part about whichever behavioural interventional approach you use is that the evidence-based cessation therapeutic approaches that are used within this cessation counselling are psychoeducation, motivational interviewing, and cognitive behavioural therapy. So it's important that the service that you refer your patients to has a smoking cessation therapeutic approach underpinned by these three main treatments. I'm going to hand over to Sasha, who's specialised in these areas, and she'll be able to talk us through.
Okay, thanks, Eileen. I'm going to start talking about what is motivational interviewing. And I suppose that is a good question. And we probably have different answers to this question. And I know that my personal response to this question has evolved over time as my experience has grown in this area. Motivational interviewing is a particular way of talking with people about change to elicit and strengthen their own motivation and commitment. It's definitely not a way of making people do what you want them to do, because believe me, I've tried with my teenager son, and it is not a way to manufacture motivation that is not already there. It's a collaborative partnership between the clinician and the patient that respects and honours the client's autonomy, and it's not about driving our own agenda for change. Motivational interviewing was originally developed in the 1980s by two clinical psychologists, William Miller and Stephen Rolnick, and they started using this approach initially to support people to change their behaviour around the harmful use of alcohol and other substances. But they soon found that the approach was very useful and applicable to promoting positive, healthy changes as well. And since that time, motivational interviewing has been widely adapted, including for use in smoking cessation. Miller and Rolnick note that they chose the word interviewing as a way to describe the interaction that occurs. An interviewer plays a guiding role. Their task is to ask questions, listen with curiosity, and learn. We wanted to introduce the topic and to share with you what we have found helpful at the Quit Line and in our own clinical experience in terms of the application of motivational interviewing when working with people who smoke and or vape. We also really encourage you to review the teaching plans about health education, brief intervention, and motivational interviewing, and the smoking cessation one that Eileen has contributed to recently, as these include links to really fantastic articles, videos, and resources. So just in terms of the evidence for motivational interviewing for smoking cessation, we know that this is an effective approach. In the 2020 US Surgeon General report, there was a review of 28 studies that compared motivational interviewing to brief advice or usual care for the treatment of tobacco use. And motivational interviewing in these studies was used in a range of settings and delivered by a range of different clinicians, but it was effective even in brief sessions, from even 10 minutes or so. So we do know it is an evidence-based approach that has been shown to be effective in increasing readiness to quit and in helping people to quit smoking. So it's really an important approach that we can try. In terms of the detail around the therapeutic approach of motivational interviewing, it embodies spirit, processes, and skills. And Miller and Rolnick talk about the early days when they were teaching clinicians about motivational interviewing. And they described that it was like they had taught them the words to a song, but something seemed to be missing. And it was actually the music that was missing. It was the spirit of motivational interviewing. So it's the underlying perspective and the qualities that we bring to the interaction. So in motivational interviewing, there are 4 elements of the underlying spirit that are interrelated. Partnership. So when we think about partnership, motivational interviewing is done with a person. It's not done to them or on them. So people are the experts on themselves. And motivational interviewing is a partnership between the expertise of the patient and that of the clinician. So they describe it as being a process that is like dancing rather than wrestling. Acceptance highlights the importance of accepting what the client contributes to the partnership without judgment, and the importance of respecting a client's autonomy to choose, not to control, persuade, or coerce. Thinking more in terms of asking, what would you like to do about your smoking? Compassion is about giving priority to the client's needs, and empowerment is helping people realize and utilize their own strengths and abilities. You have what you need, and together we will find it. 4 key processes embody motivational interviewing. Engaging is about the importance of empathic listening, building rapport, and establishing therapeutic relationship. Focusing is about setting the agenda together to guide the client in developing and maintaining a specific direction in the conversation around change. Evoking is a process that's used by the clinician to help the client find and voice their own motivations for change. And planning is about developing commitment to change and formulating a concrete plan of action. Now, I'm going to talk further about the core skills of motivational interviewing, and they cut across the 4 processes of motivational interviewing and are delivered in the spirit of motivational interviewing. And they're represented by the acronym of OARS. So the O is open-ended question, as opposed to closed-ended questions that simply provide a yes, no, or short response. And open-ended questions invite the client to reflect and elaborate so they can help us to understand what is most important to the client. And that helps to foster a therapeutic relationship. So some examples of open-ended questions you may use with your patients around smoking are, tell me about your smoking. Tell me about your day and how smoking fits in. Affirmations are statements or compliments that recognize and acknowledge the client's strengths and change behaviors, and they help to establish rapport and build confidence. And some examples, affirmations also need to be genuine, and some examples that you could use are something like, I'm so glad that you came in to talk about stopping smoking today. Thank you for being so open and honest today. I know you're unsure about quitting smoking, but I appreciate that you're willing to think about it. Reflective listening is a fundamental skill in motivational interviewing, and it helps to demonstrate empathy, interest, and understanding. It helps to clarify and explore reasons for change. And you can use simple reflections where you simply paraphrase what the client has said, or you might use reflective summaries which capture both sides of the ambivalence. So, for example, you might say something like, you want to stop smoking because you're worried about your health and your family's health, but you're unsure how you will cope with stress if you're not smoking. Summaries are really an important opportunity to check in with the client, and they help to highlight the discrepancies between the client's current situation and their future goals. And they're particularly important because they can assist with moving into the phase of action planning. So, one summary based on some assessment or open-ended questions that you might formulate with your client might be something like saying, if it's okay with you, can I just check in to make sure that I understand what we've been talking about? You want to quit because you've noticed that smoking makes your COPD worse and it costs you a lot of money, but you're worried about putting on a lot of weight if you stop. You tried patches a few years ago, but they made you itchy. You're interested in a tablet that can help you to stop smoking. Have I sort of got that about right? You check in with the client. Okay, so in terms of using the brief advice model, or whether you're using the 5 A's, you may have successfully instigated the part of the model where you've asked the patient if they smoke and you've advised them in a clear, non-confrontational and personalised manner that the best thing they can do for their health is to stop smoking. But your patient is ambivalent, and they may say things like that they're unsure if they want to change, they don't think they can do it at the moment, they're not interested, it's not the right time to quit smoking, they've tried before and it hasn't worked. And I think it's important to acknowledge that ambivalence about change is quite normal. It's about wanting to change and not wanting to change at the same time. And by using the spirit and processes and skills of motivational interviewing, we can guide our patients to explore their ambivalence for change. So I'm going to share with you a model of motivation that has been adapted by Dr. Danita Baird, who is a clinical psychologist that we work with at Quitline Victoria. And so we can understand motivation by thinking of importance, skills, and confidence. So motivation is high when the behaviour change is important, when the person has the skills to make the changes and are confident to make the changes. Motivation can be low for a number of reasons. So quitting smoking may not be important at this time, or it may be that importance is high, but confidence is low. Similarly, importance may be high, as most people who smoke are very well aware of the reasons why it's important to stop, but they don't have the skills to make the change, and so that also has an impact on their confidence. You can explore importance by asking about reasons to change. So people often report that they want to stop smoking for reasons related to health, finances, and family. You can provide patients with the skills they require to stop smoking. And so they're going to need skills to deal with cravings, to manage triggers to smoke, and also to resist the urge to smoke. You can boost confidence by encouraging a quit attempt and conveying a feeling that change is possible. You can remind your client that they can do it, and you can support your patients along the way. I think the most consistent pattern that I've observed during my clinical work and from the data I collected as part of my PhD thesis from hundreds of people experiencing severe mental illness who smoke is that they are really motivated to quit smoking. They know they need to and they want to, but their confidence in their ability to do so is really low. And so I can't emphasize enough the importance of your role as GPs in this process. And, you know, whether you choose to use a brief model or the 5As using the AAH framework, it's really important to recognise that GPs can trigger a quit attempt by helping the patient see that it is important to stop smoking and provide confidence that effective treatments are available and that you can support them. It does take time to build the skills that are required for smoking cessation. And if that's something that you have time to spend with your clients in doing that, that's fantastic. But also, if you're short of time or it's not something that you feel confident with, then it's really relevant and important that you can refer to Quitline or outsource it to Quitline. And I will talk more about how Quitline works in a little bit.
Sasha, can I just ask questions on behalf of two of the supervisors?
Sure.
I guess two cohorts of patients, one who have other smokers in the house.
Mm-hmm.
How do we motivate them, or how do we use this model to address that motivation? And then secondly, those who say, well, I'm not addicted, I only smoke when I go out or, you know, when I have the odd cigarette, but how do we address those two groups of people?
Possibly, you know, for both of them, I think both scenarios, the important part that is relevant to both those is actually getting deeper with some of these types of questions around in the spirit and the process of motivational interviewing, where we sort of delve deeper into trying to find their own personal reasons for importance. You know, what is it that, you know, might be relevant to that client in terms of wanting to make change. It's obviously going to be something that they're going to need greater support with, particularly having smokers in the house or needing greater support around those kinds of environments. But I think by getting deeper with the questions and sort of using that as motivational interviewing process to manage some of that ambivalence, hopefully that will sort of give strength to other reasons and increase confidence and then result in action and attempt to have a quit attempt.
Thanks.
No worries. So yeah, I'm just going to talk a little bit more about some of these useful questions that might help to boost motivation. And it can be in terms of exploring importance in greater detail or supporting the acquirement of skills necessary to stop smoking and boost confidence. So some useful questions around importance are, what makes you want to stop smoking? How is smoking affecting your health? How is smoking affecting your finances? How is smoking affecting your relationships? In terms of skills, we can ask our patient, what do you think will help you to stop smoking? What do you think could make it hard to stop smoking? In terms of confidence, we like to ask our client to, identify something that they might like to try between now and the next appointment, or something that they would like to try in terms of their smoking. And we ask them specifically, how confident are you to, try something? For example, it might be delay my first cigarette in the morning. How confident are you to do that? And then we get them to rate that, like where 0 is not confident and 10 is quite confident. And if their confidence is low, we explore the reasons behind that and try to help them, support them to feel more confident. So for example, if they say, oh, my confidence is about a 6, you might ask them, okay, so why wasn't it a 2? What would it be? What would you require to make your confidence rating a 9 out of 10? I think also when working with patients and exploring the aspects of important skills and confidence, it's appropriate at times to be able to provide information about smoking and smoking cessation, so psychoeducation. And this is a way to deliver such information to patients in a conversational style, in the spirit of motivational interviewing, without giving a lecture or taking on the expert role. So I thought it was helpful to share this model that we use at the Quitline in terms of the 5 principles of psychoeducation. So the first is to acknowledge the client's expertise. So you can start a discussion by asking the client, what do you know about? So for example, you might say, what do you know about ways to stop smoking? Or what do you know about medications that can help you to stop smoking? And then we listen carefully to the answers and we reinforce correct information. We ask permission to provide information if necessary, and we can do this by asking, would it be okay if, for example, would it be okay if I share information with you about ways that you can quit smoking? Or would it be okay if I share with you information about the medications that I can prescribe you that can help you with stopping smoking? And then we provide information in clear, plain English. And I think the next step is really important, and that is to inquire about their reaction to the information. So we can't assume that the information was understood or accepted. So we ask the patient to share their views. So we might ask them, what do you think about that? Or how might that work for you? And finally, it's really good practice to be able to provide some resources to your patient, and that might be written material, or you could direct them to the website, for example, the Quit National website there. And the same principles also apply to supporting your patient in building the skills that they require to stop smoking. Okay, so it makes me even feel a bit nervous seeing this heading. There's always going to be a time at some point where we encounter angry or resistant patients in our practice. And this also happens when we work with our clients to help them to stop smoking. Sometimes patients are sent to us by family members that want them to stop smoking. I've also had patients that I've seen that have been told to see their GPs by cardiologists or respiratory specialists. They've been told you need to stop smoking, your GP is going to be the one who's going to help you with that. When I was working at the Alfred Hospital in the inpatient acute psychiatry unit many years ago, we went totally smoke-free. I think that was the first time was back in 2011. And we worked with many patients that were very angry when they were admitted to the ward in the stages of an acute mental health episode and they were not able to smoke. Although, in fact, I think at the time, some of the staff were more angry and resistant than the patients, but that's a whole other story. But our angry or resistant patients may interrupt, they may present by interrupting or arguing with us. They may devalue our expertise. They may justify their behaviour or blame others for it, or they just may say that they're outright unwilling to change. In terms of how we can respond to angry or resistant clients, using the framework of motivational interviewing, we can roll with resistance. And so this means approaching resistance without judgment or argument. It's really helpful to provide an acknowledgement and a simple reflection of the resistance and to emphasize the patient's choice to change or not to change. It's up to you if you want to make these changes. And remind the patient that we are here to support them and to ask for the opportunity to check in about the topic at your next appointment. This is just a link to a YouTube video, which is also in the teaching plan, the brief intervention health teaching plan. And it's a demonstration of Stephen Rolnick, one of the founders of motivational interviewing, and the patient who has come in for a repeat prescription of his blood pressure medication. And so it's not about smoking, but he asks the patient if he can raise the discussion around his weight. And the patient gets really angry, and it's just a really good demonstration of how we can use the processes of motivational interviewing to roll with that resistance and actually move forward and keep that engagement with the client.
I'll very briefly share a fascinating anecdote which I heard at the conference in New Zealand last week as I went to a session on motivational interviewing, and one of the GPs said that they had a patient who she raised the smoking history with the patient, and the patient said, "You know what? I'm never going to stop smoking ever. I love it. I absolutely love it. It's the best thing. I'm never going to give it up." And this doctor knew this patient quite well and said something like, she thought, well, what do I do here? She said, I used to smoke and I loved it too. And I just thought it was a very human response. At the end of the consultation, the patient said, "You know what? Maybe you can give me some of that nicotine replacement stuff." And she sort of threw her hands up and said, "My goodness, you never know what you're going to get." That was one anecdote. One question, and I'd be interested in your take on this, was that a patient had responded to one of the GPs and said they really valued the fact that the smoking was raised in relation to an issue, but there wasn't any further discussion, and that the patient valued that there was no... For me, I'd be curious how you'd respond to that. I think that might have been helpful in that one patient's experience, but I'm not sure that would be the message of this webinar to apply more broadly.
I think really that's sort of the whole point of the brief advice. It's bringing up the topic, even in a situation where it may seem to be unrelated, and then the offering of the help. And the advice bit in the middle can be as broad or as narrow as what you think the patient is willing to accept and listen to at the time. And the key point is, if you're chatting with someone about, say, for example, it's an older patient who has got a wound and you need to dress it, you can just say, stopping smoking will really help with helping this wound get better, and I can help you with that when you're ready. So you haven't had to ask, are you motivated? Do you want to? But the patient knows, they expect you to ask. We know that patients expect to be asked about smoking, and the response that we get when we ask about it is really an indicator of where we can go next with our chat. And in some settings, you may have the opportunity to push the envelope a little bit more in the type of advice you offer, and you may have time to explore some of the potential ambivalence that the patient has. What are the benefits compared to just creating that discomfort that allows them to think a little bit more about, well, I will talk about that next time I come back in.
Thanks, Eileen. And just to clarify, so this is actually the first of 2 webinars, but certainly the next webinar will be covering more on vaping and the issues around vaping. There was actually a question about Quitline, but it was basically, I've referred lots of people to Quitline. What do they actually do? Do they actually really make a difference?
I have worked in the area of mental health for quite a long time, and I didn't know what Quitline was. And I didn't have confidence in what Quitline did back 15 years ago when I was working with clients in the acute psychiatry setting. Our clients weren't interested in Quitline. It wasn't something that they found helpful. But I know that over this time, and particularly now that we have our national minimum Quitline standards, our practice has improved significantly. And I really want to share with you, because I'm actually, I've seen it from both sides, and I think the service has come such a long way. And I'm really proud of the service that we provide and the high quality nature, and I will go through it. But just to provide some context, the Quit Victoria, we run the Quitline service for Victoria, Western Australia, Northern Territory and South Australia. And the other jurisdictions have their own running of their service, but it's all underpinned by our national minimum Quitline standards, and we form a national Quitline advisory committee. So we're having a workshop on Friday where we're all getting together actually in Melbourne. So we are really working very, very closely together. And this is something that is a newish thing. We haven't worked so closely together to provide such a unified approach to clients all across Australia. And I think that's actually really, really important. Quitline counsellors are behaviour change experts, and they do specialise in smoking cessation and now vaping cessation. They have extensive training with supervision and professional development and use established effective therapeutic approaches. So they're very well trained in motivational interviewing and CBT. Quitline works with a proactive callback model. So the number of calls is tailored to the client. So we have a relapse sensitive sort of timing of our calls, but we offer the opportunity to have a number of calls before making a quit attempt. And that's designed to try and help the client to get ready, but also to explore ambivalence and to use that motivational interviewing to help the client work out, where they're at. So a client doesn't have to be ready to quit to ring the quit line. That's what the counsellors are expert at. So, even if they're unsure, making a referral to Quitline is a really positive step. And our counsellors will work where the client's at and tailor the counselling to them. So we can have flexibility in the number of calls, and generally we have set calls at different points along the quitting process. But most intensive calls are the first one or two, which are based around assessment. We have very structured call components in our model. And so the assessment is quite a detailed process, and it may take over 2 calls, but it's really individualized, and it's about understanding the client's smoking and vaping behavior, exploring their motivation, providing that reflective summary, and then helping the client to facilitate their goals and plan for treatment. Psychoeducation is tailored, as I spoke about the principles of psychoeducation before, but it's tailored to the client, as is the skills building. And then we have a focus on self-efficacy and planning, so supporting the client to identify what they would like to achieve before the next call and asking them to rate their self-efficacy to try that strategy and explore reasons and problem solve if the confidence is low. We pride ourselves on being able to offer an inclusive and, as I said earlier, multi-session intervention for people who want to address their smoking and vaping. And we have tailored protocols for priority populations. So in terms of the Aboriginal and Torres Strait Islander people, we offer Aboriginal and Torres Strait Islander counsellors. We have dedicated counsellor for each client whenever possible. We have a yarning narrative approach, and there are unlimited calls for people who are Aboriginal and Torres Strait Islander. In terms of people who are pregnant, we have call scheduling throughout the pregnancy and into the postpartum period, and we also offer support for families, partners as well. In terms of people with a mental health condition, we have extra call attempts, extra calls. We focus the psychoeducation on the mental health benefits of cessation. We offer very important monitoring of their moods and experiences as they make their changes, as well as medication side effects. And we can make contact with their treating health professional if there is any deterioration in the person's mental health, obviously with their consent. People with substance use disorders, we focus psychoeducation tailored towards that population in terms of stopping smoking, how it can also help with stopping alcohol and other drug use. And we can provide support to people wherever they are. So if they're in an inpatient rehabilitation setting, we can provide support over the phone there. And we can also offer referral to other drug and alcohol services. In terms of young people, we are really focusing our Quitline approach on this population, and we have a dedicated counsellor for young people. We have youth-friendly practices and very detailed assessment using the heads, and I can vouch that any youth caller to our Quitline, every call from a young person, that is taken to supervision with our clinical psychologist to ensure that we are doing the best that we can for the young people that are calling and using the Quitline service. In terms of the culturally and linguistically diverse clients, we can link in with the translating and interpreting service, and also some services have bilingual counsellors, and clients with hearing or speech difficulties, we can use the National Relay service. It's really easy to refer to Quitline. You can go to the Quit Centre webpage and click on Quitline referral, and you just select your jurisdiction and you can fill out the relevant referral form. It's really important to make that proactive referral to the Quitline when you're with your patient as a GP from your service, because asking clients to just go off and call 137848 really works. And so, it's really great to have that proactive referral. And in fact, research has shown that doing that proactive referral can increase the uptake of the service by about 13 times. It's really great to know that the service is free and it's professionally tailored callback counselling at times to your patient that are suitable and convenient to them. And what's really important too is that we respond very quickly once we receive a referral within 2 business days, and we make multiple attempts to contact the patient. And the really important thing is that we provide written feedback, acknowledgement of the referral, and actual written letters back to GPs with the client's consent or their referrer, explaining at the end of our time with the client how they've gone, what they've achieved, what their future goals are, where the GP might want to pick up from here. So that's a really important part of what Quitline has to offer.
So there was a question about whether the same counsellor is available for each call.
Yep. Okay. So for general callers, we don't generally have the same counsellor unless there is a particular reason we can request that. But generally, we do have a dedicated counsellor for Aboriginal and Torres Strait Islander clients. We have quite a frequent request for clients with mental health conditions. We can ask to have a key worker for clients, understanding that that can be a challenge for people with severe mental illness. And definitely we do absolutely for young people.
That's great. And I think I'll just remind all of us as GPs that if we make the actual referral ourselves, if we go on, we sit with the patient and say, I'm so pleased that we're going to go ahead and make the referral, let's just do it right now and fill in the form, then that means that the service is free and that within 2 business days, they will receive a call from Quitline rather than requiring the motivation to go away and do it themselves. So that means that the patient is much more likely to engage with the service if we make the referral at the time. So if we're really short on time and that's all we get to do in our consultation, we're already on a winner.
I think that's a really key message maybe to take away and to teach registrars as well. There was a couple of Q&A questions. Does Quitline encourage pre-quit patches?
Quitline counsellors can provide general information about smoking cessation pharmacotherapy. Generally, they do refer clients back to their health professional to talk about specifics, but they can provide general information around using the pre-quit patches as an option. So they talk about the approach the client wants to take, whether it's cutting down to quit and how they can use NRT in that process. So they definitely do discuss that as an option.
Yep.
A formal referral is not required. Patients can call Quitline themselves. And another good point is that patients may not answer a call if it's an unknown number. So when Quitline calls the patient back, and I had never thought of this one, Sasha, so this will be new for me as well.
What happens is once we receive the referral, we send a text ahead of time to let them know that they will be receiving a call from an unknown number. And when the referral is made on the referral form, the client or the patient can select, sort of timeframes that they would prefer to be called. And so we really try to put that time frame in the call queue and send a text message ahead of time to prepare the client that we're going to get a call from an unknown number and it's going to be the Quitline.
Thank you, Sasha. Thanks, Eileen. What we would like you to do is to have a look at those teaching plans that have been revised. So there's a consultation skill 1 on motivational interviewing and health education, and there's also one on smoking cessation, a clinical one. Use those. We encourage you to have a play with those with your registrar or other learners in the practice. Obviously, encourage your registrars to implement some of this with their patients as you might yourself.
There's just one little point on patients very rarely come in just to talk about smoking cessation, and that the form would take at least 3 to 4 minutes to complete, which is actually true. It depends on which form it is. So if you're in New South Wales, I think some of the forms are longer than others, but other people can fill in the form for you. You can get your nurse to do it. There's a range of sort of time-saving approaches as well. But if we remember that filling the form is actually the treatment that we're offering, then that's a short investment of time to help the patient access an amazing service.
Very good. So a big thank you. It reminds me of a story a colleague told me of a general practice he walked past on some suburban street in Sydney, and on their glass window was about 17 dot points of what they offered: pap smears, contraceptive advice, travel health. And right at the bottom, with a bit of paper, somebody had stuck on the last dot point, which was counselling. Almost sort of this afterthought that we do all this stuff. Oh, no, we also do counselling. And it reminds me that what we've talked about tonight really is about, as sort of fundamental as what we do in our jobs as GPs as anything else. It's about encouraging people to change their behaviour and live more healthily. So thank you so much. I learned a lot tonight. I'll use this in my practice and look forward to seeing you guys again.
Thanks very much.
Thanks,
Thank
Alex.
you.
Good night,
Thanks,
everyone. Bye-bye.
Good night. Bye.
Bye-bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.